So the next talk is on the actual PQLI, that is the quality of life for the patient. If we give these patients a lot of medications, the patient actually, the conjunctiva and the whole equilibrium of tears become deranged. And these are the patients who are who developed a lot of dryness, lot of surface related issues, and that itself result into non-adherence or the non-persistence of the patient to their treatment regime. So it's a kind of catch-22 situation. And we have to take these patients for a proper treatment, and proper healing of the surface is required. To talk on this, may I invite Dr. Mamta Singh, who has done D-Ophthalm from RIU Chennai, DNB Ophthalmology from Gujarat, and a fellow, he is a cornea and refractive fellow. She is pursuing her senior residency from Patna Medical College Hospital. She is also editor proceeding of Bihar Ophthalmological Society and member editorial board of IZOC, and a proficient presenter for the Bihar Ophthalmological Society. Dr. Mamta, please deliver your talk.
Thank you so much, sir. Am I audible there?
Yes.
Okay. So thank you so much, Dr. BP Sinha, sir, for making me a part of this IC, and thank you, AIOS, for this opportunity. And I will be talking about the association of dry eye with glaucoma and how to fight out this dreaded association. If we talk about the prevalence of dry eye in glaucoma patients, it's quite high. One of the study involving 20,506 glaucoma patients has reported that 56.9% of women glaucoma patient and 45.7% men glaucoma patients dry. And there was a clear relationship with the number of eye drops and prevalence of dry eye. Those who were using one anti-glaucoma medication, 11% of them had dry eye. Those on two anti-glaucoma patients, 39% of them had dry eye, out of which 8.7% was severe dry eye. And those who were on three anti-glaucoma medications, 43% of them had dry eye, out of which 15% was severe dry eye. So we have a large number of glaucoma patients with dry eye. And if we talk about the pathogenesis of dry eye in glaucoma patients, it's basically the pro-inflammatory nature of the ocular surface which is causing this. The long-term use of anti-glaucoma medications leads to dysfunction and loss of goblet cells, meibomian gland, and accessory lacrimal glands. There is an increased risk of subepithelial fibrosis. Over the surface of cornea, there is disruption of corneal epithelium and reduction in corneal sensitivity. All this leads to disruption of homeostasis of tear film and ocular surface. And this pathogenesis is related to the number of daily drops, the duration of treatment, and the presence of preservatives in this anti-glaucoma medication. If we talk about preservatives, then the most notorious was zirconium chloride or PAC. It is a quaternary ammonium compound which severely disrupts the ocular surface and alters corneal sensitivity, related with more severe ocular surface disease and worse quality of life. The toxicity of benzalkonium chloride has found to be dose dependent, and reducing the overall number of drops will decrease the prevalence of ocular surface disease related to BAC.
Dr. Mamta, may I request you to just stop your video so that your network works well?
We'll do that. We'll do that, sir. Just 1 second. Let me stop share and then we'll do it again. Sure. Am I audible and visible, sir?
Yes, please go ahead.
So I was saying it was about beta blocker, and particularly the preserved timolol maleate. They disrupt the tear film stability, reduce basal and reflective tear secretion, cause geriatric changes in conjunctival epithelium, but potentially leading to cicatrization. As we can see it here, there is some clear fibrosis due to timolol maleate. Prostaglandins, on the other hand, they have least effect on conjunctival fibrosis, although they cause conjunctival hyperemia. Prostaglandins induce obstructive meibomian gland dysfunction, more with preservative-containing regimen. And it's not just anti-glaucoma medication, as Dr. Ravi said, glaucoma surgery There is an increase in tear osmolarity, corneal epitheliopathy, filamentary keratitis, and gelen formation. So if we have a patient of glaucoma with symptoms of foreign body sensation, dry eye, etc., then we need to evaluate these patients. We should take a history, like if the patient is simultaneously using any other ocular medication or any systemic medication like antihypertensive, anti-allergic. These medications are known to cause dry eye. We need to assess the tear volume, do Schirmer, do tear meniscometry. Osmolarity, if available, should be evaluated. TBUT and non-invasive TBUT definitely should be done. Ocular surface stain and interval assessment, especially if the patient is on prostaglandins, this should be assessed. MMP9 for confirmation of inflammatory status of ocular surface, and confocal microscopy for the overall sensitivity and how the cells are there over the surface. This all, whenever available or wherever possible, should be done. Then comes the treatment of these patients. The idea is to minimize or to modulate the ocular surface inflammatory response. And this is central to both patient comfort and improving IOP control, because if there is a subepithelial fibrosis, definitely the IOP is not going to be there. So in fact, for better controlling the glaucoma also, we need to have a good ocular surface. And there are two guiding principles of it. The first one is to minimize the effect of glaucoma on ocular surface, and the second is to treat ocular surface disease as early as possible. So coming to the first part, that is treatment modification. The first line should be switching to preservative-free glaucoma medication. But in a status of ours, the costlier preparation of preservative-free preparations definitely cannot be given to everyone. We have options like UNIPS, Comode preparations are there, but these are not for everyone. So what we need to do, we need to switch to safer preservatives, the non-BAC preservatives like Puride, Softgea, and we have multiple options now that we can go for. And the cost effective are definitely much better than the preservative-free preparations. The second way to decrease the overall exposure of BAC is by using the combination topical hypertensives, like glandings with beta blocker or beta blockers with carbonic anhydrase inhibitors and so on. So these are very much in practice now. The third option is shifting from anti-glaucoma to other mode of installation, like the bimatoprost sustained release, which is created by placed in the inferior angle of anterior chamber. Bimatoprost ring can be inserted circumferentially in the fornix. The microdose delivery system for latanoprost, which gives just the sufficient amount of drop to the ocular surface, not to cause the ocular surface problem. iDose is a travoprost loaded titanium implant, which is placed in the Slen's canal through the sclera. Delivery system for latanoprost and travoprost. All these can be used whenever possible or whenever it is available. The second arm of treatment modification is using laser or minimally invasive glaucoma surgery. LIGHT trial, that is laser in glaucoma and ocular trial, has suggested that SLT can be very well used as a first line of treatment in early glaucoma patients. They give similar result as any topical medication, but it is cost effective. Similarly, if it is possible, one can go for minimally invasive glaucoma treatment surgeries like microstenting or trabeculotomy or viscocanalostomy with or without cataract surgery wherever possible. The next part is the treatment of ocular surface disease. The first step is obviously the use of lubricants, preferably preservative-free. The next step would be tackling the ocular surface inflammation. That can be done by using topical low potency steroid or any potency steroid, whichever is required. Topical cyclosporine or the newer compound levetirast or Xiidra, which is coming in a big way. For mild case of ocular surface disease, the idea would be to replace one BAC containing preparation to a BAC feature. We need to do with the control of the IOP. So we will and if that is not enough, we will be switching one by one till all the medication back. We can plug application And if the patient is having MG, we treat it by warm compress or LipiFlow, etc. So treating a glaucoma patient is just not about treating the IOP. It's also about taking care of the psychological need of the patient, the socioeconomic burden which is there over the physical handicap which comes with glaucoma, and then the most important ocular comorbidity like ocular surface has to be taken care of. With this, I would like to say thank you to all.